Okay, we're going to talk about spina bifida. Spina bifida is basically all neural tube disorders of the spinal column. It is usually found in the lumbosacral region, but it can be as far up as the cervical region of the spine. There are two types of spina bifida. Spina bifida occulta, which means hidden, and spina bifida cystica, literally meaning that there is a cystic involvement. There's two types of spina bifida cystica, and that's meningocele and myelomeningocele. So some of the risk factors or causes of spina bifida are the maternal use of drugs, certain types of medication, malnutrition, maternal malnutrition, exposure of the embryo during development to chemicals, and genetics can play a part. Also folic acid, because again, we're talking about a neural tube defect. So they have found, the studies have found that the use of folic acid pre-pregnancy can decrease spina bifida by 50%. So spina bifida occulta, again, means the hidden type of spina bifida. The cues include basically, well, you can't really see it because it's hidden. It is a defective spinal column. It's usually in the lumbosacral region. There is no protrusion. There may be some small dimpling, a tuft of hair, or discoloration of the skin at the level of the defect. Frequently, no one knows at all until they reach adulthood and suffer from maybe leakage or dribbling of urine or stool. And when they're being worked up for the reasons why, maybe an x-ray or a KUB is done and it's noted that there is spina bifida present at the lumbosacral region. And that's usually what's causing the dribbling of urine or feces. There are really not many complications other than what I just mentioned happening in adulthood. The complications are rare, and this is a relatively benign disorder. For instance, I have spina bifida occulta and didn't even know it until last year or earlier this year. I don't know. Diagnostics, we can find it on MRI, x-rays, CT scans, and the management is just to educate parents that it is rare and usually benign. So these are some pictures of the dimpling that I'm talking about. So there are measurements of the dimpling that would lead a practitioner to do more frequent, not more frequent, but to order more invasive diagnostic studies. So if we found a larger than 5 mm dimple with discoloration at the site, and you can see some slight discoloration of the skin here between the practitioner's thumb and forefinger, right above the level of the dimple, that might lead them to want to do an MRI of this neonate to be able to find out if there's any other problems going on along the spinal column. This picture of the tuft of hair is, that's a lot of hair in that region, but it's not always that way. Sometimes it's just a few strands of hair, but they seem to be misplaced and too long or too dark, not like the typical peach fuzz that we see on little babies' backs, or even the hairiness that sometimes we see all along the back and the cleft of the buttocks in like a Hispanic or person of color neonate. Okay, so we're going to talk about the first type of Spina Bifida cystica, which is called a meningocele. It is the less serious of the two types of Spina Bifida cystica. This is where the meninges are herniating out of a defect in the vertebrae, but there might not necessarily be any opening. The spinal cord is still normal. There is typically no neurological involvement whatsoever. These children are completely neurologically intact, and they might have a need for some surgical correction, but we don't expect them to have a lot of disability overall. So as far as nursing management of these babies, we need, and you can see here on this picture, this little girl has a very large meningocele, but she looks otherwise healthy. She might have some difficulty with her lower limbs, but they look pretty good size to me. And usually when there's disuse, there's also wasting and atrophy, and it doesn't look like she has that. So she's probably able to at least crawl, if not walk. So we ask parents to report any leaking CSF from the defect itself. We also provide supportive management pre and post-op by preventing rupture of the sac, preventing infection. So really educating very well on good hand hygiene when we're dealing with these babies, both pre and post-op. Assessing and managing any constipation, assessing and managing any bladder dysfunction. These children might need to be catheterized frequently throughout their lives, depending on the level of dysfunction they might have. And then we also want to assess and manage any possible hydrocephalus. So we really want to know what the infant's baseline is and assess from there. So this is what would be called myelomeningocele. It is the most severe form of spina bifida. It can be diagnosed in utero, but it also can be a very devastating finding in that if we have a mother who is unable to receive prenatal care for any reason, they might not have an ultrasound to be able to guide this being a possibility for birth. So then they would give birth vaginally, and most frequently this would rupture and would cause brain death because they're going to have such a severe and quick loss of cerebrospinal fluid that their brain would likely herniate. So we would prefer to know ahead of time that this is coming, and prepare for it, have the NICU team there and available for the high risk birth, and they would do a C-section to be able to remove the baby appropriately without injuring the sac. These children are at risk for meningitis, hypoxia, hemorrhage, infection, and they are likely to have absolutely no motor or sensory function below the level of the defect on the spine. And this defect, like I said, can occur anywhere up to the cervical region. So that child would be a complete paraplegic with no motor or sensory function below the neck. Here is a picture of the typical posture and positioning that has to be maintained both pre and post-operatively for neonates born with spina bifida cystica type myelomeningoceles. The very first thing we do, even if the cyst is still there and visible and has not been surgically reduced, we need to prone the baby, although there are some Resources that say that side lying is okay. If I'm the NICU nurse, I would be uh, less likely to put the neonate in a side lying position because I think the likelihood for it to put pressure on one side of the sac is too high. So I would have them prone. We use positioning aids to keep their head turned so that we can turn them from side to side. And we offload the pressure on their little, you can see their little elbow is not touching the bed. Their knees will not likely be touching either because we kind of just want them to hang so that we don't get pressure ulcers. Um, they will be fed usually via NG tube. Um, and we catheterize them frequently, at least every 2 hours in the neonatal period before and after surgery, because they're going to have uh, dysfunctional bladder. They'll have what's called a neurogenic bladder. So they will not be able to control their urine or their bowel. So we do bowel training where we do timed enemas or suppositories. We try to maintain a latex-free environment because these children have such sophisticated medical need and they are in a latex abundant environment. So they will develop latex allergy over time, and we want to kind of mediate that risk if we can by removing latex from the very beginning. Um, we need to really maintain these babies' body temperature while kind of dancing a dance with the risk of drying out the sac. So these babies are going to be naked, as you can see here. We don't cover them with a diaper. We might put a diaper underneath them and just barely up or between the legs to catch any, feces or urine, but we won't ever hook the diaper to them because it could put pressure on the sac. We are going to try to keep the sac itself moist and persistently wet as well as protected. So we surround the sac with wet, sterile gauze. So we use sterile gauze soaked in sterile saline, and we cover the sac with it or kind of make a little donut type ring around the sac. And we are monitoring it frequently for breakdown, dryness, rupture, um, and pressure points. And so in doing that, we also need to keep this baby warm because they're naked and covered in wet fluid. Um, so we have them under a radiant warmer or in an isolette, but those environments can be very drying, which can dry out the gauze and the sac and lead to rupture. So we have to be very specific about the monitoring of these babies. It's going to be much more frequent than Q2 hours. It's likely going to be a Q1 hour, and the nurse will be assigned to this baby in a one-to-one, meaning that they won't have other patients. We try to promote as good a family bonding as we possibly can and really get parents to spend as much time with the baby as possible, speaking to it, rubbing its face, touching its little hands, and trying to not be frightened by the appearance of what they're seeing. But we have to be there for support. Um, and there's going to be a certain level of fear as well as maybe being nervous that they're going to hurt the baby by touching it, or that they're going to, that they maybe are at fault for what's happened. So we have to provide a lot of um, emotional support as well as educational support for these families, because this child is going to have lifelong problems with mobility, possibly with their neurologic status. They're likely going to have some form of developmental delay, language delay, motor delay, and we're really going to be quite unsure as to what the level of deficiency they might have neurologically until they start to age. Um, One of the things I want you guys to know is that in this baby, aside from possibly using an enema or a suppository, we are never, as the nurse, going to take a rectal temperature on these babies, because the likelihood that we could rupture something on the inside or hurt them worse than they already are is very high. So absolutely no rectal temperatures, only axillary. Um, and we will frequently have just a little temperature probe on their body. It's like the little heart that you see in the NICU. The temperature probe will be there to give us a constant update on what their temperature is, but we'll never let someone do a rectal temperature.